This podcast is sponsored by Bark. Bark is the standard for internet safety software. They aim to keep your child safe online and in real life. Bark monitors devices, emails, apps, texts, social media, even photos, and more, no matter where your child is using their device. And now they've just added a new feature where you can filter content, monitor screen use, and a whole lot more. It really is the total package. I have searched high and low and haven't found a better platform. They truly are on the cutting edge of protecting your children online. They were recently featured in the documentary Childhood 2.0 on YouTube, something I think every parent needs to see. You can get started on protecting your child today by going to our website, thekidfactory.org, and click on the Bark link. That will give you access to a 1-week free trial period as well as 20% off the monthly fee. Plus, for every person who signs up with Bark through our link, they will send us a $50 Amazon gift card that we'll use to keep our community project going. So thanks for the support. And thank you for working to keep your child safe. Okay, today's topic is pandas. And what is that? Well, it stands for Pediatric Acute Onset Neuropsychiatric Syndrome. That's a mouthful and a mindful. And Dr. Eric Fier is the perfect person to help me sort it all out. He's a pediatric psychiatrist, and he has specialized in the link between infections like strep and the sudden onset of disorders such as OCD for nearly his entire career. This is a syndrome that is often misdiagnosed and even more often misunderstood. Dr. Fier perfectly explains it and gives parents the tools they need to identify and treat it. This may be the most essential episode for you to share with others this entire season. So please listen and please share.
Go, Mommy! Go! It's just the best mom ever. You are the best mom ever.
This is the Kid Factory podcast, and I'm your host, Cindy Robinson. The Kid Factory is a not-for-profit aimed at finding cutting-edge tools for healing both our families and ourselves. Come join me as we take a deeper dive into all things parenting and mental health. But before we start this part of our journey, don't forget to subscribe to this podcast, as well as follow the full journey at thekidfactory.org. Okay, now here we go. What is pandas?
Right. So I'm not sure that actually your premise is accurate. I don't know that anyone really understands pandas. And my sense is that probably 5 or certainly 10 years from now, we're going to look back on our current pseudo understanding of pandas and probably see it quite differently. But as we at least understand it now, it seems to be a model in which specific infectious and secondarily inflammatory triggers seem to bring out the sudden onset of OCD symptoms and perhaps secondarily tic symptoms. We think the mechanism is, at least in the pandas model, we think it's a strep trigger, but that it's not actually the strep which is triggering the symptoms. In a more typically autoimmune-like model, it's really our body's reaction to the strep which is driving the symptoms. So what we'll see, like in rheumatic fever, where your body makes antibodies against strep, which then may, in rheumatic heart disease, cross-react with specific markers in your myocardium, right, in the sac that surrounds the heart, that then triggers a whole inflammatory reaction, which can then cause changes to the heart muscle. We think that in pandas, our body's autoimmune reaction to the strep antigen, meaning the strep antibodies that we make to fight off the strep, begin to cross-react with specific receptors in the basal ganglia, meaning in the part of our subcortical brain tissue that seems to be heavily involved in OCD and in movement disorders. So we know for people with Tourette's and with other chronic sort of movement disorders, the basal ganglia is really the part of the brain that seems to be most intimately affected by such. We think that when we have the cross reactivity between our body's our body's immune response to the strep trigger that then cross reacts against the tissue in the basal ganglia, that a subset of kids seem to develop the sudden onset of severe and incapacitating OCD symptoms and changes, sometimes very, very severe changes in restrictive eating patterns, and sometimes in the emergence of rather severe motor or vocal tics. When we see that, when we see the emergence of these symptoms, and we believe that they are occurring relatively acutely, right? Not a more gradual, insidious onset, but
Hmm.
rather acutely. And we can create or find a temporal association, a time linked association between a recent strep infection and the sudden onset of these symptoms. That's the model that we believe exists for pandas. Now,
Wow.
we've sort of expanded the diagnosis to what we call PANS. So PANDAS technically stands for, it's a kind of a cute sort of acronym that
It's
was
an
coined
interesting
by,
name, yeah.
yeah, that was coined by Sue Sweeto at the National Institute of Mental Health back in the 1990s when she first identified PANDAS. It stands for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcus, right? So it was basically this model that was identified based on infection with group A beta hemolytic strep. There are multiple different forms of strep. It seems to specifically be group A strep that is the one most typically associated with pandas. What we began to see over time is that while strep is often the first trigger for the pandas process, after someone has had a strep trigger for pandas, they perhaps are somewhat more susceptible or vulnerable to other infectious and inflammatory triggers thereafter. And
Mm.
so we do see some kids who may develop pandas like symptoms, but there's actually no evidence of recent strep infection. But we do find that they had a recent mycoplasma infection or another type of infection, usually bacterial, sometimes perhaps viral. That remains a little bit less clear, and sometimes even perhaps a spirochete-based infection, meaning like a tick-borne illness like we see in
Oh.
Lyme disease and things like that. Now, whether that can be the first trigger for this process or whether strep is always the priming factor and then the brain becomes more vulnerable to secondary infections is not entirely clear. But the umbrella diagnosis of PANS, pediatric autoimmune neuropsychiatric syndrome, really was created to make greater room for the possibility that maybe there are other non-strep infectious triggers that can ultimately result in the same downstream symptoms that we see in pandas, meaning the sudden fulminant onset of OCD, very severe restrictive eating changes, the onset of motor and vocal tics, and then a whole set of secondary neuropsychiatric symptoms that many parents will describe in terms of anxiety, irritability, behavior changes, academic decline, physical symptoms, sleep changes, etc. And so that sort of is our current probably kind of crude and simplistic understanding of the mechanism of PANDAS and PANS, my sense is that probably over time, we're going to really have a much more nuanced understanding of how lots of different infectious and inflammatory triggers probably are part and parcel of a multifactorial sort of illness model
Yeah.
that can give rise to lots of what we see in mental illness. There are already, mounting levels of evidence of the role of inflammation in certain forms of depression. We see that in certain individuals with schizophrenia, there may be viral triggers much earlier on in life that may have laid the even during pregnancy with the individual who ultimately develops schizophrenia. There may be certain viral triggers that have already primed one's system for the development of mental illness. And so I think that we're going to begin to look beyond simply a chemical imbalance model of mental
Mm.
illness for schizophrenia, for bipolar, for OCD, for depression, for other anxiety syndromes, and really begin to look at sort of the interface between our neurology and our immunology and, dietary factors and,
Yeah.
so much else that all probably come together to create sort of a risk vulnerability model that lends it that creates a higher propensity towards illness, maybe in individuals who already have some level of genetic predisposition. Does that
Right.
make
Right.
sense?
It does make sense, I think about as much as it can. But it seems like what you're ultimately telling me is that you've unlocked not you personally, but just it seems like we're just starting to open the door on this and understand how interactive the brain body connection really is. We knew
Very
there was a connection, but this seems like you said, we're just at the elementary level of really understanding this.
Very much so. And you have individuals that are in all different areas of medicine and affiliated sort of fields that are looking at, leaky gut hypotheses and what's taking place. When does our blood brain barrier begin to become somewhat more metaphorically porous in a way
Mhm.
that allows for things that are supposed to stay peripheral to begin to become central, right? When do our neuropsychiatric symptoms really begin to manifest as a result of certain fundamental breakdown in the protective mechanisms that are meant to keep certain things separate and apart? And I think that as we look at the microbiome, right, as we study sort of what's taking place in our gut, throughout our intestines, the role of our bacterial colonization in number one, creating the neurotransmitters that healthy brain function depends upon, but also the role of dysbiosis, that when we really are fundamentally out of balance in our gut, how is that impacting what our brains are seeing and doing, and even the vulnerability of our nervous system to other sorts of factors? So maybe many of us can develop all different infections that never seem to really affect us. Here's a great example. Part of the challenge that we run into when we're looking at individuals who have a spirochete infection, who have a tick-borne illness, is that the capacity for um, the spirochete, for the bacterial element within the tick, whether it's Lyme, whether it's ehrlichiosis, whether it's Bartonella or Babesia, all these different spirochetes can sit quietly in our system for years. without doing any visible damage or wreaking havoc in any discernible way. So if someone doesn't necessarily notice the brief rash that they may have after a tick bite, or not realize that they were bit by a tick, or not experience or notice any particular joint pain that may occur in the days to weeks after an initial inoculation, they may then be asymptomatic for years. What happens then? It may be 5 years or 10 years later that their system experiences some level of vulnerability
Mm.
for whatever reason, whether it's a gut issue, whether it's another infection, whether there's something else that is creating a certain level of porosity, right, of porousness in their in some of the mechanisms that keep things in balance and separate. And all of a sudden, the spirochete that's been sitting in your nervous system quietly and in a dormant sort of state is now allowed entry into your central nervous system, and suddenly it starts to wreak havoc. But because it's been years since a tick bite that you may not have even been aware of,
Right.
you don't automatically make the connection between what happened, years earlier and what's going on in your system now. So I think that when you think about sort of some of these models of the way that infection and inflammation and neuropsychiatric symptoms can unfold, part of the challenge is that it doesn't always follow a very clear temporal sort of course. If it was as simple as I got sick today and my symptoms show, I got ill, physically ill today with an infection, and my psychiatric symptoms manifest immediately afterwards, it's a little bit easier to make some of those connections.
Right. Yeah.
What may actually be the case is that there really is a significant time delay between infection and neuropsychiatric decompensation. And that's where we sometimes miss the relationship between those. And the intermediary sort of factor is that something else has shifted in our vulnerability now to some of these organisms that may have been living dormant within us. So
Mm-hmm.
and that generates then for parents and families a
Right.
great degree of confusion, because it's very hard when your child suddenly becomes sick, especially when when, like we see in pandas, kids can literally overnight go to sleep normal and wake up absolutely disabled by their symptoms.
Right.
It's very hard to sort of sometimes, if there isn't a clear identified infection or a clear identified preceding illness, do I just call this regular OCD?
Right.
Is there something else that could be contributing to this? Can stress alone do this? And
Well,
really
and that's
trying.
I mean, that's certainly my next question is like, how do families what is this gonna really look like to families for them to question? Because I feel like a lot of parents are gonna be listening to this right now, like, wait, is that my child?
Right,
That's my hope, honestly.
right.
So what are they looking for? Because like you said, it can be dormant. I think that's so helpful to understand. And
So I
then what
think
are they gonna see in their day-to-day life that's gonna be like a big clue that this could be what's really happening with them?
So the problem with any new diagnosis is that initially you have some criteria that are laid out for what makes the diagnosis. And then over time, as the diagnosis becomes increasingly recognized and popularized, sometimes the parameters around which um, we define that illness seem to get a little bit loose and wider, and suddenly it's now a spectrum illness, right? It's no
Mhm.
longer this is what you have. Now you're on the spectrum, right? So
Yeah.
we've seen that with autism. We've seen, where people that never would have been diagnosed with autism 30 years ago, they were just called nerds or geeks or they just went to Georgia Tech. Now, everyone who's a little bit quirky or a little bit sort of, part versus whole is somewhere on the spectrum, right?
Yeah.
So, and that actually has sometimes great benefit in understanding our own neurology and composition, but it can also have a little bit of a dilutional factor that sometimes steers us away from what the right treatments are. We've seen the same thing with bipolar illness, where, we used to have reasonably strict criteria for what made a bipolar child. And then, it seemed to stretch to the point where almost any child whose mood switches rather abruptly and intensely and is really extreme in their explosivity seemed to be collecting bipolar diagnoses, even if there wasn't necessarily a strict
Right.
adherence to the previous criteria. So with pandas, what I try to remind parents all the time is that just because your child is obsessional, just because your child is perseverative, just because your child has a tic, and just because your child did have strep at some point in the past year, or even has strep antibodies in their system in the past, 6 months, doesn't mean this is pandas. So this
Hmm.
is a really important thing to understand. Number one, pandas is by definition, and I think it's important that we retain this, the sudden onset of OCD. If your child has had moderate OCD symptoms for months and months, and they've gradually sort of increased. And it began when they were around 7 or 8 years old, and now they're 9 or 10, and their OCD is just getting worse. So, could that be pandas? I won't say it absolutely can't be, but that's a much more typical presentation of regular OCD. I am much more concerned about an infection triggered OCD process when parents tell me my child went to sleep normal and they woke up on Thursday morning at 7:30 in the morning, unable to leave their room without touching the door 7 times, without walking 3 steps backwards and 2 steps forward. They would only eat the following foods that morning at breakfast, and they were describing an enormous level of fear around a whole host of irrational things that we have never heard about before. That presentation, the sudden onset of OCD that wasn't there yesterday and certainly wasn't there 2 weeks ago, is much more indicative, I would say almost um, pandas until proven otherwise,
Hmm.
suggestive of an infection triggered process, because OCD doesn't show up overnight in a typical sort of OCD pattern, right? It usually is a gradual, insidious sort of onset. When you see something come on that suddenly, think about infection, inflammatory factors. Now, there may be other things that can there may be other models that we have yet to discover besides strep and mycoplasma that may trigger the sudden onset of OCD. Right now, pandas is about as good as we have in terms of sort of understanding that. So, when one sees the sudden onset of OCD, I'm going to qualify that a little bit, that even though OCD is the primary symptom cluster that we're looking at, if we see in certainly also, but possibly even instead, the sudden onset of avoidant, restrictive food intake, okay,
Hmm.
where all of a sudden my child becomes much, much more restrictive about what they're going to eat. And it feels like it has, or it clearly has nothing to do with body image, right? We're not
Right.
talking about the sudden onset of anorexia or bulimia or eating disorders that are intimately connected with a self perception, right? That
Hmm.
I'm overweight or that I'm, et cetera. Specifically, when it is a fear about putting this food in my body and how it might adversely affect me,
Hmm.
right? and all of a sudden the kids stop eating or become exceedingly restrictive in their eating habits, that also is recognized as being one of the core hallmark symptoms of pandas. Now, most kids don't have that particular eating set of symptoms, but a significant minority of pandas kids do. And so we do use that as one of the primary sort of symptoms. Now, everyone wants to understand where ticks fit into this. Ticks are harder because they, by definition, are sudden onset, right? So any of my kids with Tourette's, right? Tourette typically develops also elementary school age. Age 8 is usually, I think, the average onset, so around third grade. Some kids even kindergarten first. Some kids not until a little bit later into early adolescence develop tics. But listen, tics are essentially not there until they are. Okay,
Right. Yeah.
so it's hard. You're not really almost always when parents say my kid suddenly started making these noises or doing these movements or making these funny sounds, that wasn't there until it was. So that is almost always sudden onset. So I won't say that that is as strongly indicative of a pandas process, because even in regular non-infection triggered Tourette's, you do see the sudden onset of tics. So I tend to sort of emphasize it's really the sudden onset of OCD, which is much more atypical for
Hmm.
regular OCD. Regular OCD is a much more gradual build up of anxieties, obsessions, and then secondary compulsions before it really sort of becomes severe. The classic pandas manifestation is really semi-acute to acute, and very often parents can tell you the day, the
Yeah.
time that their child got sick. When I hear that or see that, even though many of the medications that are helpful for treating OCD in a non-pandas OCD child will ultimately be of possible benefit in a pandas OCD child, that's probably not where you want to start. And so that's an important take home point for parents that many discover the hard way, is that if it is an infection triggered OCD, presuming that that is driven by a level of inflammation at the level of the basal ganglia in the brain, psychotropic meds very often initially have a pro inflammatory effect.
Oh, wow.
What that means is that even though they can be helpful, they sometimes really can inflame things first if you don't first bring down the fever, right? And I'm speaking metaphorically. I mean,
Hmm.
probably literally as well if they have a fever,
Yeah.
but you really want to bring down the inflammation first before you start the Zoloft or before you start the Prozac. And that's where, if it is a sudden onset, identifying or trying to identify what the infectious trigger is, coming up with a thoughtful plan for how to treat that infectious trigger if it is still present in their system, and then coming up with a thoughtful anti inflammatory plan to really bring down the volume on the level of inflammation that the child is experiencing. That really is how we begin the process of treating these kids, as opposed to treating kids who have a non infection triggered OCD process.
Yes, and I definitely, yeah, I was going to ask you about treatment. I wanted to ask one thing quickly, that circles back to when you were talking about like what parents are going to notice the sort of, and I agree with you. One thing I consistently hear with just the people I know in my life who've been diagnosed with this is
Yeah.
there was a before and an after.
Uh-huh.
And but another thing also that I'd say 2/3 of the people that I know who have been diagnosed, there was a behavior component before and after as well. Like, I frequently hear Yes, about the OCD, but also about like their personality changed as well. What is that? Is that just a response to the symptoms that they're experiencing, or is that also like can you see behavior changes maybe being the biggest sign? I just know of a couple of people who were really struggling, and it was mostly behavioral that they noticed more so than OCD. Is that also a thing to look for? Like an immediate aggression or something like that?
So it's a really important question. Certainly, if we are seeing an acute behavioral change, in the absence of discernible OCD symptoms, we want to carefully evaluate whether what is driving the behavioral change might actually be unrecognized obsessions. Not everyone with OCD has C. Some people have primarily or pure obsessional OCD symptoms, which means if a child is having horrific intrusive thoughts about sexual themes, about aggressive themes, visualizing,
Oh,
horrific, gory, murderous sort of themes that are, by definition, ego dystonic, meaning this isn't what I'm enjoying. I don't like thinking about this. I don't like picturing my mother getting assaulted sexually. I don't like picturing myself stabbing my father in the chest. Why am I thinking these horrible, intrusive thoughts?
wow.
A child, especially a younger child, may never vocalize what's actually going on in his head for two reasons. Number one, it's really embarrassing to say that I'm picturing you, mommy, getting assaulted, or my assaulting you, even worse. Number two is that at that age, there's a lot of magical thinking. If I say it out loud, if I talk about it, does that somehow make it even more real or more possible? So sometimes we'll end up seeing real behavior changes in these kids, but it's not really occurring in a vacuum. It's occurring as a manifestation of what is shifting in their thinking. And if you're constantly being tortured, literally tortured by
Wow.
thoughts of really the most horrific things your imagination is able to come up with, right? And OCD basically takes whatever the worst thing you could think of would be for you, right? So no one who is not religious, okay, has religious OCD obsessions, right?
Mhm.
It people that have a strong spiritual sort of base will then have oftentimes intrusive obsessional thoughts about hating God or about
Mhm.
sinning against God. If
Wow.
someone has, very, very strong, belief systems about something, the OCD will make them doubt whether they really believe that. Meaning your OCD knows what you hold sacred, and that's what it goes after. So
Ah,
for children, the kind of stuff that will manifest um, in their OCD will often be the things that are really most precious and most sacred to them. That can certainly come across in the form of severe behavioral symptoms because
yes.
it's quite miserable, and it's quite
Yes.
torturous.
They're
Now,
so friggin' smart.
yeah,
That makes so much sense, and I forget I get lumped in. I haven't had to struggle with this as a parent, so I forget the wide range of what OCD can manifest as, and
mm,
I tend to think of it as repetitive actions or cleanliness, these sort of stereotypical versions of
sure.
OCD. I forget, and you laid it out so perfectly. That's probably exactly what's happening with these kids.
Now, we can also use a little bit of what we know from Tourette syndrome and apply that to our pandas kids, meaning some kids with Tourette's really only have a motor tic and a vocal tic, is essentially the definition of Tourette's. When you've had at least one motor tic and at least one vocal tic that are present more days than not over the course of a year, they can be waxing and waning, but once you've had that for about a year of symptoms, you are officially Tourette. But the majority of people who have Tourette's also have some other symptoms that are part of the basal ganglia sort of family of symptoms. And that's where my prediction is that we will eventually move away from the cutesy acronym of PANDAS and probably start calling this a basal ganglia encephalitis. You'll already
Mm.
hear that term being used. We talked about an autoimmune encephalitis, but I think more specifically a basal ganglia encephalitis. And what we know the basal ganglia also controls, besides movements, right? So we know it's involved in Parkinson's, right? Which is why as you run out of dopamine, you can start to freeze up. But what we know that the basal ganglia also impacts is ADHD and mood regulation and
Mm.
OCD and tics. So really the quartet of symptoms that we often see in people with Tourette's is attention issues, oppositional defiant behaviors, OCD, and tics. And so when you think about sort of that, the explosivity, the rage attacks, the inability to modulate one's reactions to small triggers, the attentional and learning deterioration. These are things that we see in our pandas kids, meaning they're not really, sometimes it's just OCD, but very often together with that, we are seeing changes in their learning patterns. Sometimes it's quite dramatic in terms of the changes in their learning profiles, with much greater difficulty sustaining attention, changes in their working memory and in their processing speed. Sometimes you'll see deterioration in their handwriting and in their ability to sort of just motorically to sort of complete tasks that they used to do much more easily. And then you'll see a level of emotional behavioral sort of dysregulation that either may be a product of, like I said, underlying, unrecognized, torturous, intrusive, obsessional thoughts, or really just the dysregulation that comes with the basal ganglia being inflamed and
Mm.
people looking a lot moodier, a lot
Yeah.
more brittle, a lot more labile, explosive, aggressive. And especially when that doesn't match their
Right.
pre-morbid sort of functioning. So if your kid's always been an explosive, violent child, it's hard to use those criteria as being indicative of a acute basal ganglia encephalitis. On the other hand, if that really hasn't been your child's nature, and all of a sudden they have just become miserably aggressive, explosive, reactionary, hypersensitive. Some will describe their sensory symptoms, right? We see this across many disorders and, autistic spectrum and, all the sensory processing symptoms. But when suddenly your kid is just intolerant of certain noises, certain sounds, they develop misophonia, right? Certain
Mhm.
noises just drive them insane. Certain textures with their clothing suddenly become intolerably sort of frustrating for them. You have to wonder whether there really is an acute inflammatory process at play. And sometimes when it comes to treatment, if you want to shift to that, one of the
Yeah.
most, one of the cheapest and most primitive but reliable litmus tests of whether what we are seeing is reflective of an acute inflammatory process is a short course of prednisone.
Oh.
So it's often been the cheapest and easiest litmus test we have for whether this may be a PANDAS process. There is nothing about regular OCD that should make it come down significantly when you give someone 5 days of a steroid, right? It's
Mhm.
not the way OCD or tics normally, they don't, they're not driven by, as far as we know, inflammatory cytokines. And so giving someone 2 milligrams per kilogram of prednisone for 5 days shouldn't make a difference. In my pandas kids, I'll almost always, I'm going to give a little caveat to that in a second, but I'll almost always begin treatment with a 5-day steroid burst. And I'll tell parents, we'll start with some prednisone. We're going to pick a dose between 1 and 2 milligrams per kilogram per day. We're going to divide that twice daily into a morning and an early evening, late afternoon dose so it doesn't impact their sleep at night. And I don't expect you to see any positive difference on day 1 or on day 2, and maybe not even on day 3. By day 4 or 5, as that steroid is really getting into your kid's system, tell me whether they look markedly better. If all
Mhm.
of a sudden, most of us don't look calmer and less agitated on steroids. Sometimes we get hyper, sometimes we get giddy, sometimes we get overly silly, sometimes we get rageful and explosive. But steroids don't, for most of us, have a calming effect. If your child looks measurably better by day 4, 5 on the prednisone, chances are inflammation is a major factor in what's driving their clinical symptoms. And so that can be a really cheap and easy litmus test for a pandas child. Now, here are the caveats about that. Number one, if your child's been symptomatic for a really long time, those are sometimes my hardest kids to treat and to discern because it is possible that what takes place at the beginning of a pandas process is not the same as what's taking place 9 months or 12 months down the road. It may be that we go from kind of an acute inflammatory illness to a more chronic autoimmune illness. And the
Mhm.
same thing that works at the beginning may not work later on. This gives rise to some of the confusion around the Cunningham panel, right? It's one of the blood tests, or probably one of the only, sort of quote unquote tests for pandas. And it looks at a couple different markers, receptors, or autoreceptors in the basal ganglia that may be triggered by an infectious process, an autoimmune sort of infectious trigger. And there's a measure called CAM kinase 2, which is really sort of a marker of immune reactivity, but it may not be the same. And our ability to interpret those results 2 weeks into the pandas process may be very different than 12 months into the pandas process. And so it does matter where we are in the trajectory, which really sort of brings us back to the point that early intervention is absolutely positively the best thing you can do for your child,
Yeah.
because once it's gone on for a while, not only is it harder to treat, it's also harder to discern what's really happening here. Early on is when we're going to have the best window of into the information and the data and even some of the testing that's going to be more meaningful in helping us discern what's driving this and how we're going to treat this. The other caveat, this is a lot of words, I apologize.
No, we need to know all of this.
The other caveat is if your child is actively infected with something, you don't want to start with a steroid. You really need the antibiotic first because, as most of us could understand, a steroid is going to lower your immunity temporarily. If you're actively infected with strep, you really want to treat the strep first before you add in anything that might sort of lower your body's resistance to fighting the strep. So, the order of operations really, when I see a new patient who I suspect has pandas, you want to number one, get a really good, and when I say really good, meaning like your kid needs to almost vomit on the pediatrician's shoes.
Hmm.
Okay, a really good throat culture. If they're not gagging, the likelihood of a false negative is dangerously high.
Oh,
And a
yeah.
false negative is a problem because then you're going to assume that something isn't there that might really be. So even though none of us like that feeling when someone touches our, the back of
Oh
our
god,
throat with a
no.
cotton swab, it's worth making your child miserable to get a good swab. Okay, so number one, you get a good swab. You don't just want to send it off for the rapid test because there are a lot of false negatives with the rapid. If the rapid is positive, there are not so many false positives with the rapid. So you can be pretty confident that there's an active strep infection if your rapid comes back positive. But if it comes back negative, make sure your pediatrician still sends it off for culture. The reason for knowing whether you're strep positive has nothing to do with the blood tests that we're going to talk about in a second. You want to know whether we have to actively treat your child for a current infection. If they're strep positive, you really need to make sure to get those antibiotics started right away. Okay. Now,
Hmm.
sometimes the source of the strep may not be oropharyngeal. It may not be colonizing in your child's oropharynx. That's a little bit of a longer discussion that we won't get into, but sometimes we do more detailed cultures. If we really find that there's strong evidence of strep in their system that's not coming down, their titers don't seem to be falling, could they have perianal strep?
My son
Certainly.
had that. We called it the booty strap.
Wow, wow. So, I am a very devoted psychiatrist, but there are limits to where I'm going to go with my patients. But I will tell them, please go to your pediatrician to check this out. So, certainly, if a child has a significant level of redness or itching perianally, if there's any strong indication that there may be something going on downstairs, not just necessarily in their throat, it definitely is worth doing a culture for group A beta hemolytic strep there. So the first step is definitely doing a good culture. The second step is getting baseline blood work done. Now, it's really important to understand that none of the blood work is diagnostic for pandas. It is suggestive. So when parents say to me, "Oh, my kid was tested for pandas and he was negative," that really means nothing to me because there is no absolute test. It is a whole, and that's really where having a team or having a doctor that understands pandas, basal ganglia processes is so important because it is more than just strep titers and strep culture and antibiotics. You really have to look at everything symptomatically that is going on in your patient, and then a whole host of different sort of potential contributors that could explain why we're seeing these symptoms. And then you come up with a hopefully cogent, coherent hypothesis that links it all together. And then you design a treatment plan based on that hypothesis. That's a hard thing to turn into a flowchart. There are
Yeah.
some really good flowcharts out there that do guide pediatricians and psychiatrists for how to sort of think about these things. But in very brief, which is not going to be very brief, what I'll say is this. You want to definitely check your child's strep antibodies. There are two main ones. There used to be a third one called streptozyme. It's typically so unreliable, we don't really use that. But we do use ASO, your anti-streptolysin O titer, and your anti-DNase B, that's DNASE dash B titer. One of those peaks a little bit sooner, one of those peaks a little bit later, but typically following a strep infection relatively quickly, we see a jump in our strep titers. Now, strep titers have nothing to do with the strep itself. That is our body's reaction to the strep, the immune response that we are making, a B
Mhm.
cell mediated immune response to fight off the strep. The value of having a set of titers of antibodies is that it gives us some perspective um, on um, on whether the individual is likely continuing to be experiencing some level of inflammation, meaning the inflammation that's driving the symptoms is not because of the strep bacteria any longer. It is almost exclusively in the realm of the way that these titers, these antibodies, are cross-reacting with tissue in the basal ganglia. So I explained to parents that after we've already treated the strep infection, why your child often still remains at least somewhat symptomatic is not because there's still strep living in their system. It's because they still are retaining some antibodies to that strep that are driving the inflammatory process. And it's really important that families understand antibodies don't disappear when the strep disappears. With strep antibodies, typically, they're going to stay present in your system anywhere from 6 months, even up to 12 months after the original strep infection. So, what that means is that even after you've treated the infection, if someone has had elevated strep antibodies driving their symptoms, if our bodies naturally take 9 months to clear those antibodies by themselves, your child may still remain at least moderately symptomatic as long as 6 to 12 months after those antibodies first presented. Okay.
Mhm.
So the way that we then go about targeting those symptoms is really by trying to dampen the body's immune response or the level of sort of autoimmune reactivity to whatever it is driving that level of inflammation. And that's where the role of anti-inflammatories, non-steroidal anti-inflammatories, antihistamines, even antibiotics that have a strong anti-inflammatory profile. So, for example, I use a fair amount of Zithromax in my pandas kids. The benefit of Zithromax is that it's a reasonably broad spectrum antibiotic that works not just for strep, but also for the second most common driver of PANS symptoms, which is the Mycoplasma bacteria. So it works for both strep and Mycoplasma much of the time. There is some Zithromax resistance seen in some parts of the country with strep, but still by and large, it's a very effective agent. But the other benefit of that family of antibiotics is that it also happens to be a very strong anti-inflammatory in addition to its antimicrobial properties, its anti-infection properties. And so sometimes when parents notice that we go off of our Zithromax and my kid becomes symptomatic so quickly right after we stop the antibiotic, it is possible that they just got reinfected by a family member, but what's more likely is that now the Zithromax was providing a rather potent anti-inflammatory benefit independent of its antimicrobial benefit, and that the
Ah.
continued benefit of that anti-inflammatory effect is keeping the level of noise significantly reduced in your child's brain as they gradually clear the antibodies that are driving the PANS or PANDAS process. And so there is an argument to be made, certainly for kids that have a very clear cut PANS or PANDAS process and are more than mildly symptomatic. So if I have a kid who's really suffered as a result of his PANS or PANDAS symptoms, and it's very, very clear to me that this was a strep or mycoplasma driven inflammatory process, I'm going to treat them for the acute infection if it's there, but I'm also going to keep them on some level of antibiotics, oftentimes for at least a year after the
Mhm.
infection. And the role is not because they're still infected with strep, but because it really is essential to prevent reinfection. If their titers, let's say at their ASO titer is elevated at 450, and then it comes down 3 months later to 300, and then 3 months after that, it's down to 220. The last thing that I want is when we're almost getting to the subclinical range, their symptoms are improving, the antibodies are finally clearing their system, and hopefully the autoimmune response is coming down and resolving. the last thing that I want is for them to get another strep infection
Sure.
and to start the clock all over again with a new set of antibodies and a new set of inflammation and all of that could then go on for another 6 to 12 months. And probably there's reason to believe that each successive episode of PANDAS does increasing damage to the brain, meaning it's harder to treat these kids over time as they have more and more infections, which gets back to a really important point that the key to effective treatment is early intervention, because what we can accomplish in the first couple weeks after the symptoms first manifest is often much more robust than what we can do 6 months or 9 months after they've been symptomatic. There's increasing evidence that the disease process may be different at the beginning. It may really be much closer to an acute, inflammatory, autoimmune sort of model that responds really well to antibiotics, anti-inflammatories, and antihistamines. A year down the line, it may not be an acute autoimmune inflammatory process anymore. At that point, it may be more like a chronic autoimmune illness that really then requires much stronger and often more toxic interventions to get kids well. So really being able to intervene early is essential.
If you have any questions about this episode, please submit them to me. Dr. Fier has agreed to do a follow-up podcast to address any of your questions. Also, if you think your child would benefit from seeing Dr. Fier, go to therapyworksatl.com. His office is the coolest, by the way. If you're not in the Atlanta area and you want to find a physician or psychiatrist who can treat you or your child, you can get some great information at pandasnetwork.org. PANDAS network.org. Yay, you finished the whole episode. For more about the Kid Factory, go to thekidfactory.org or follow us on Instagram at _kid_factory. Cindy also sees parents and teens individually for parent and intuitive healing coaching. All of that information can be found on the website. Again, it's thekidfactory.org.